So why is snake antivenom so expensive? And what can be done to improve access in remote parts of Africa? I put these questions to Professor John Amuasi, a member of the Global Snakebite Task Force. I began by asking him about the dangers of relying on traditional treatments.
See, the challenge is that when it comes to snake bite, there are no proven traditional remedies that address envenoming. Not every snake bite would be envenoming, i.e. the snake may bite, but it may not be a venomous snake, or it may be a venomous snake, but the nature of the bite was such that no venom was injected. It's very tricky. So you may have cases where someone says they were bitten by a snake or had an encounter with a snake, they went to a traditional healer and they got better. The probability that they were envenomed is very, very low. Or it could be a bite from a snake which just would cause some local swelling and not very much. And technically, if you're just giving paracetamol and cleaning the site, the swelling would have gone down anyway. So we have a false narrative of, some traditional medicines work, and so we must not discount traditional medicine, etc. We're not discounting traditional medicine on the grand scale or on just using a broad stroke to brush aside traditional medicine. No, what we're saying that when it comes to snakebite and venoming, there is no traditional remedy for this. And so being able to work with the traditional healers, at least grant them the tools to be able to stabilize people who come to them and then to push them to a health facility, we can solve this problem.
And talking about standards, the World Health Organization has warned that low demand for antivenom has driven some manufacturers out. Now, what practical demand generation or market shaping tools do you think would bring suppliers back into the market?
Manufacturers respond to prices, they respond to predictable demand. It's a market. So what we need to do is to create an incentive, an economy for the production of high-quality, life-saving antivenoms. Some of the practical tools I'd like to suggest are, just an example, multi-year volume commitments. So what we call advanced purchase agreements, where a country or even a bloc, let's say ECOWAS, would agree we're going to be pooling procurement and we're going to be storing X quantities in ABC medical stores, and we would push them using a certain formula based on known incidence rates of snake bites and so on. That way, the manufacturer can say, I know that there is a market for this, that at least X amount will be procured, I will manufacture. Then there's also the risk-sharing agreements. This would reduce manufacturer uncertainty, for example, guaranteed minimum orders. And then things like support for regional manufacturing. This is so important. Technology transfer, strong regulation, making sure that while you're transferring technology, the manufacturing is to the highest standards possible, and that when one is manufacturing, it's not all about manufacturing sovereignty. And this is one of the tricky parts about vaccine manufacturing, especially antivenoms. The economies of scale have to be there. It has to match the market. Everybody cannot manufacture their own. It does not make sense. It's not cost effective. So this is why addressing the manufacturing, stocking, and supply of antivenoms is a discussion that cannot be at a national level, needs to be at a regional level.
Now, frontline workers say about 99% face challenges administering antivenom, according to a recent survey by Strike Out Snakebite, also called SOS. It's a global initiative. Now, what are the top barriers you see often, and which one could be fixed fastest with modest investments?
The two barriers that I see most often, the first one is the unreliable availability of quality assured antivenom. And the second one, like they point out, is limited clinical confidence and systems to deliver it safely. So this includes being able to recognize that there is envenoming, being able to make the right decision regarding the dose to give, and then, more importantly, being able to manage any adverse reactions. These, I think, are the two most critical barriers that come up. So first, it's got to be there. And then once it's there, how do you use it? And the one I think we can fix fastest with relatively modest investment is the clinical confidence and safe delivery systems. And this will call for targeted training, decision support tools, stocking of emergency medicines in case there are reactions, and then simple things like mentorship through referral links. So you can meaningfully reduce deaths even before the wider supply chain problems are fully solved.
Now, studies also show that half of facilities lack full capacity to treat snake bites. What are the minimum readiness standards a primary healthcare center, which is mostly what we have in many African countries, especially in our rural communities?
Great question. And what I think at minimum a primary facility should be able to do is first be able to recognize that there is envenoming. It's amazing, but sometimes the frontline healthcare workers or the facility, they may not necessarily recognize that there is envenoming.
Many thanks to Professor John Amuasi, member of the Global Snakebite Task Force.